Our colleagues in immunobiology have really done a lot of work with regard to the underlying mechanisms in which there's a local kind of tumor-induced immune suppressive effect on the infiltrating lymphocytes and immune cells in the tumor microenvironment. It's sort of like the tumor develops a mechanism to kind of silence the immune system. And of course, understanding the mechanism sometimes leads to therapeutic insights. And that's happened with regard to the programmed death receptor, or PD-1. We know that PD-1 is expressed on immune cells in that tumors can express the ligand for that, PD-L1 and PD-L2, and that this is an inhibitory stimulus. And so development of mechanisms to combat either PD-1 or PD-L1 intuitively makes sense. So now we have several antibodies being developed in non-small cell lung cancer, some to PD-1 and some to PD-L1. It's not clear which is the better strategy. There are different mechanisms of action. The data that we do have thus far is that with both PD-1 as well as PD-L1 agents is that there seems to be a consistent response rate that's between the range of kind of 15 to 25% or so. And one of the remarkable things about the responses is that many of these responses have a great deal of durability, suggesting that if you can re-engage the immune system doesn't forget. You know, it continues to suppress the tumor. All of them have largely, once we've understood what the toxicities are, which are very different than you know, standard cytotoxic chemotherapies or the TKI, a class of drugs. These are immune-related toxicities that will all have to become facile at managing and those sorts of things. You know, I think that the age of immunotherapy is upon us. I think there clearly is a role for immunotherapeutic agents in lung cancer. The data suggests to me that it's going to be a huge and substantial benefit for a minority of patients. It will not be a treatment that benefits everybody in this particular setting. Now, having said that, there are other inhibitory molecules as well as stimulatory molecules with regard to this immunobiology understanding that perhaps we're going to see new therapies down the road. So perhaps where we think we can benefit 15 to 25%, that we can grow that with newer combination strategies. And you know, everyone is engaged in several phase 1 trials of combining these immune checkpoint inhibitors, such as the PD-1 compounds with the anti-CTLA-4 compounds. And those are kind of just in the phase 1 to early phase 2 sorts of things. So the safety and efficacy is yet to come from those trials, but certainly has created a great deal of enthusiasm and excitement for immunotherapy in non-small cell lung cancer. The true role of how it fits in with our current standards of care, remember, as enthusiastic as we are about the early data with immunotherapy, it is largely from phase 1, early phase 2 trials with no comparator arms in selected patients. And so the question always comes up is, you know, how good is the drug? How good are the patients that get treated with the drug? You can certainly make mediocre drugs look really good with good patient selection. You can make really, you know, really good drugs look bad with bad patients, so to speak. We don't quite have enough data relative to our current standards of care to know, will it replace our current second-line choices? Or in which patients will it replace, for instance, docetaxel or other agents in this setting?